In this video, we will be presenting about the enucleation of periapical lesion and apicoectomy of tooth number 11. Enucleation is a process by which the total removal of a cystic lesion is achieved. By definition, it means the shelling out of the entire cystic lesion without rupture. Enucleation is the treatment of choice for removal of cyst of the jaws and should be used with any cyst of the jaws that can be safely removed without unduly sacrificing adjacent structures. Apicoectomy is the surgical resection of the tip of the tooth and its removal together with the pathological periapical tissues. For the preoperative procedure, the patient is asked to gargle 15 ml of 1% povidone iodine for 30 seconds to decrease the risk of introducing septic materials into the soft tissues, producing inflammation or infection. For the basic dental instrument, we need two mouth mirrors, a tooth explorer, a cotton plier, spoon excavator. For the anesthesia, we need 1% povidone iodine, a topical anesthesia, a cotton swab, aspirating syringe, a number 27 gauge short needle, a 2% lidocaine with 1:100,000 epinephrine in 1.8 ml cartridge. And these are the other armamentarium that we are going to be using. Dry the surface of the skin first before applying topical anesthesia using a cotton swab to temporarily numb the area specifically for about 1 to 2 minutes before anesthesia induction. Using a number 27 gauge short needle for a labral infiltration, the penetration area will be on the mucobuccal fold height above the apex of the tooth being anesthetized. Aspiration is important to prevent inadvertently indirect intravascular injection of the anesthetic solution that may cause undesirable systemic effect to the patient, especially when using a vasoconstrictor that may lead to toxicity or tachycardia. For a palatal infiltration, the penetration area will be on the attached gingiva 5 to 10 millimeters from the free gingival margin of the tooth being anesthetized. Submarginal scallop flap is a variant of the rectangular one, replacing the sulcular incision with the scallop submarginal one. Using a blade number 15, we made the horizontal incision along the attached gingiva from tooth number 12 to tooth number 21 and two releasing incisions starting from the end of the horizontal incisions of tooth number 12 and number 21, run apical. Using the broad end of the mucoperiosteal elevator, reflect the full thickness of the flap, exposing the root apex. Using a number 6 long shank surgical round burr and a steady stream of saline solution, the bone covering the root tip is removed peripherally, creating an osseous window until the apex of the tooth is exposed. The removal of the periapical lesion will be done using a hemostat and curette, then irrigate. After copiously irrigating the area, resection the apex of the tooth using a flame diamond fine burr and beveling it at a 45-degree angle. The resection faces the surgeon and is at a distance of 2 to 3 millimeters from the root tip. We irrigate the canal and root surface with Perigard as an irrigant, then preparation of the cavity at the root tip of tooth number 11 using the microhead handpiece with number 4 long shank surgical round burr. The filling material is to be placed on the cavity that was created after controlling the bleeding using cotton pellets. MTA or mineral trioxide aggregate for retrograde filling is bactericidal and may stimulate osteoblasts to produce bone to fill in any defects caused by infection. Bone filler or alloplastic graft material using bio-os mixed with cancellous bone from the socket, then placement of matrix collagen membrane that will stay for 3 months promoting bone regeneration. For the suturing technique, we will be doing a simple interrupted suture, starting from the distal gingival sulcus of tooth number 1211 and distal gingival sulcus of tooth number 21. Then about 3 to 4 stitches of simple interrupted sutures on the oblique incision up to the vestibular fold of tooth number 21 to retain blood clot in the alveolar socket for faster healing and hemostasis. We will be prescribing 500 milligrams of amoxicillin. Take 1 tablet every 8 hours for 7 days. And 500 milligrams of mefenamic acid. Take 1 tablet every 6 hours for 3 days or as needed. For the post-op instruction, the patient should follow and take the medication as prescribed by the dentist. A cold compress must be used as well to help address the swelling. Patient should eat soft, room temperature foods for a few days after treatment. Avoid anything that is crunchy, tough, or that has crumbs. The patient should avoid using the treated tooth for biting food for a couple of days until it is fully healed. Brush teeth at least twice a day using a soft, bristle toothbrush. Gargle an alcohol-free mouthwash that promotes saliva production and helps mouth naturally flush out bacteria. Recall the patient after a week, especially for suture removal. For the clinical history, 7 years ago, the patient undergone a root canal treatment on tooth number 11, then treated in the clinic. Based on the pathological report, the lesion was a phoenix abscess.